So we have two strategies for intervening at the level of prediabetes. Three, really, because initially one has to diagnose prediabetes, which requires screening. And although the ADA has come down on the side of hemoglobin A1C measurement for diagnosis, I'm rather concerned that hemoglobin A1C may overdiagnose in some situations, such as African Americans and older individuals who tend to have a higher level of A1C for a given level of glycemia. And it may underdiagnose. Individuals who have more rapid erythrocyte turnover will tend to have a lower A1C for a given level of glycemia. But whether one uses glycemia screening with fasting glucose or with glucose tolerance testing or A1C, we know that a large number of individuals in our society have prediabetes, probably twice as many as have diabetes. So let's say something on the order of 60 million persons. Those individuals are at variable risk of developing diabetes depending on the severity of their hyperglycemia. And so how do we prevent diabetes? Number one, absolutely, is lifestyle modification. So we know that if we take individuals with prediabetes and we have them in a program of intensive work on diet and on physical activity, we can reduce the likelihood of developing diabetes by 2/3. That's really something that we are rarely able to achieve with pharmacologic therapy. So I would always work with individuals in that fashion in trying to prevent diabetes. But let's say I take an individual with prediabetes and I do it based on fasting glucose. Let's say the fasting glucose is 105, and then the next time I check it, it's 112, and then the next time I check it, it's 119. Well, there's no reason to wait until it gets up to 126 at the next measurement, where they officially do have diabetes, or similar with hemoglobin A1C. And so in such a case, I would use pharmacologic therapy. And 3 classes of drugs have been studied and have been shown to prevent diabetes. Probably more of the diabetes drugs would have such an effect. So metformin reduces the likelihood of diabetes by about half as much as lifestyle intervention. Still, that's not bad, 30% reduction in diabetes. The thiazolidinediones are much more potent, but they do have the side effects of weight gain, edema, skeletal fractures from bone loss, and so these are probably not as desirable. There is evidence that alpha-glucosidase inhibitors, which are not commonly used in the United States, but are widely used in some countries in Europe and in Asia, may actually be moderately effective in reducing the development of diabetes, and these are certainly options. The GLP-1 receptor agonists have been shown in obesity therapy trials to reduce the progression from prediabetes, and so have a number of obesity-directed drugs per se. And so we do have a variety of choices in preventing progression from prediabetes to diabetes.